Good morning. This is Andrew Colsky with Stop My OCD, and we are here today with Terri Pilkeron, who is a therapist who works with clients in Virginia. And we're going to be talking with Terri about her experience with clients with OCD. Purpose of these videos is so that other therapists can understand what to expect when they might be working with a client with OCD, and also for other people to understand what therapists are thinking. So, Terri, thank you for joining us, and I'll ask you to just introduce yourself and tell us a little bit about your background.
Yes, hi, I'm Terri Pilkerton. I'm a licensed professional counselor, and my office is in Falls Church, Virginia. I am kind of a little late to the game. I had a background in marketing, but I came to be a therapist about 15 years ago. So I specialize in trauma. I use internal family systems and cognitive behavioral therapy. I also like other therapies such as Tantra and expressive arts.
Fantastic, fantastic. So with an LPC, that means that you got a master's in the counseling field, correct?
Yes.
Okay. So one of the questions that I ask all of my students and any of the therapists that I work with is, out of curiosity, can you remember back during school, did you ever have any classes or any lectures or anything about OCD?
I did not.
That's the typical answer. So far, we're at 100%. And it's unfortunate. And it's, understandably, when the schools are teaching therapists all about all the different types of issues out there, there's a lot of stuff to cover. And there's certain requirements that they have to cover. And OCD, for whatever reason, tends to be overlooked. And I know my own experience, I've shared this before, is I came out of school and I started working with patients. And at some point I became aware of OCD, and I looked back and I saw, some of those clients that I had worked with earlier probably had OCD, but nobody trained me on it and I wasn't aware. So that's one of the reasons that we do these videos, is to help educate people about OCD and what it's like. So tell us, how did you first get involved with OCD?
Well, my very first client was a little boy, and he had what I later learned was emetophobia. So it's a fear of throwing up, seeing throw up, him throwing up himself. So that was very interesting. So I started to educate myself about it. And what's interesting with him is that it was in the middle of the COVID transition. So I had to work with him virtually. So we did do some exposure. We were able to do some exposures virtually, believe it or not.
Wow. So when you say you did some exposures working with him virtually, can you tell us a little bit more about what does that actually mean, so that if someone is watching this and they're a therapist who's never dealt with OCD, what does exposure mean to them?
So exposure and response prevention therapy.
Mhm.
So basically what we did with it, what he did was he made some concoction in his kitchen during our session. And he took oatmeal and applesauce and just made a bunch of gunk and put it in a bag. And then he went outside and he threw it on the ground as if it were vomit.
Wow.
Another time he took a bucket, which when his family was sick at one time, they would use to vomit in. So that bucket itself cued him up for that fear. So he would stand in the bucket. That was an example of one of his exposures during our therapy sessions. And additionally, he would rate his anxiety level. He did a scale of 1 to 5. And then during the week, he would have some homework, and he listed a hierarchy of his fears. He was afraid of bugs. He had different things, his greatest to his least. And then we would start somewhere, around 3 or 4, his third or fourth scariest thing. And he would work on that for homework. And then we worked our way up to the biggest.
Very, very creative. I like that. I like the ideas you came up with there.
He was a very creative kid. Yeah.
Yeah.
So it was amazing how successful it was.
Yeah, well, what you're talking about points out the fact that OCD is so unique and individual to each patient. They all have different things that cause their obsessional doubt. And one area that is always a subject of conversation when I'm speaking to therapists who have not done OCD yet is when I describe exposure and response prevention therapy, and I describe that the goal, or one of the goals, is to expose the patient so that we trigger their distress and actually raise their distress in order to help them ultimately lower it. You see a lot of people who are very anxious and nervous about that. Oh, I don't want to do that to my patient because I don't want to make them feel uncomfortable. And so they're scared to enter exposure and response prevention therapy. Any thoughts about that for those who might be watching the video?
That was very difficult for me because I'm a very nurturing type of therapist and I want to comfort and rescue. And that was very difficult. And with one of the patients, which I'll talk about later, I'll call him Jack. We have been working together for years and I was that typical, comforting. And so I had to tell him before we started the exposure and response therapy that I wasn't going to comfort him, that he was going to get a different therapist this time around. And it was a little bit, at first, difficult for me to allow him to experience the level of discomfort that he did initially.
Mm-hmm.
But I see how well it works now, so I have no problem doing it.
Great. So today, given the experiences that you've had up to this point, is it fair to say that you're comfortable diving into exposure therapy with any patient when you perceive that that's the correct course for them?
No, I really am. I'm surprised. I thought it was going to be really difficult.
Mm-hmm.
But you were actually the person who trained me, and you did a really good job. And it's very formulaic, so that's what made it easy for me to do. All I had to do was follow the formula. Was able to consult with you, and I'm really surprised at the because this particular patient was in his 40s and had been dealing with this for basically all his life. His OCD started in childhood and took on various forms. And we had been working, I had been trying different kinds of CBT to no real avail. He was making progress in some parts of his life, but there were some specific OCD behaviors that weren't really calming down, so to speak, for him until we did this. And I want to say 6 weeks about, but it was a lot sooner than I thought. I didn't know how long we'd be doing this because I had been treating him for so long and he had the symptoms for so long, but it was a relative short amount of time.
Mm-hmm. Yeah, and that's been my experience as well. Is once you actually start the exposure therapy, it's surprising how quickly you get results compared to traditional talk therapy and other things.
Absolutely.
So when I'm talking about how other therapists who have not done exposure therapy have this concern that they don't want to raise their clients' distress because they feel they might be hurting them and all that. But ultimately, now that you've described your experience, at the end of the day, even though your client's distress did have to get raised to do the therapy, at the end of the day, are they better off or worse off for doing exposure therapy?
I think he and they would say they're much better off.
So a little bit of distress to get to a point to alleviate the main distress.
It's, yeah, with so many things in life, and this is one of them.
Yeah. So did you know any of the clients that you've spoken about so far, did they have any particular unique concerns or fears or anything about engaging in the therapy, or were they willing participants?
Yeah, they were afraid. It's very scary, and of course, fear causes us to want to avoid what it is that triggers the anxiety. So they were afraid. They were also afraid it wouldn't work and that they would be broken forever.
Mm-hmm.
That kind
Yeah.
of, yeah, there was some initial fear, but they were also at a point where they were desperate for some relief. And
Right.
so there's a lot of motivation there.
So, in your lifetime, just not even necessarily your professional lifetime, but just in your lifetime experiences with different people, had you ever experienced or been aware that you were experiencing someone who was dealing with OCD?
Yes, my brother has OCD.
Oh, and how has he had that ever since he was a kid?
He has, and unfortunately, he's one of those people who has refused treatment.
Mm, that's
Uh,
hard. That's hard. Well, but at least it's available. You really did have a good understanding of what that was like, even before starting to professionally treat OCD.
Absolutely. And at that time, when he was younger, I think thought stopping was the uh, whatever therapy of choice, which I think we know now is pretty much the opposite of what we do.
Mm-hmm. So, speaking about that, the other treatments, and you were saying that you were working with one client for a while with regular talk therapy, and you weren't seeing the successes. And then when you started the exposure therapy, so, you know, oftentimes, I guess a great majority of the times when I speak with therapists who have not been trained in OCD and maybe aren't recognizing that their client has it, the traditional approach that they take, and it's what they're taught, is to maybe use cognitive therapy or cognitive behavioral therapy. They may try to teach some calming techniques. They may try to um, uh, teach yoga or mindfulness. There's so many things, and now that you've done the exposure part, what would you what advice would you give to a therapist who calls you up and says, Terri, I've got this case and it's just not getting anywhere, and then you realize this sounds like OCD? What would you tell that therapist?
Well, I would probably talk about that and also talk about the ERP and how it's worked for me and my patients.
Okay. And you said that you did the exposure remotely, at least with the first little boy you were talking about. How did you personally, as a therapist, how do you find remote telehealth type of work versus in-office work? Is there a difference for you? Are there pros and cons?
There are pros and cons. Right now, what's coming up with telehealth is that insurances are not covering it as much. But honestly, that was another surprise that I had, was that it does work. You can do exposures via telehealth. And with the adult man that I worked with, we were fully remote.
Mm-hmm.
There's, a few things you can't with telehealth, like I couldn't see his legs, all the, any shaking body movements, although we were able to adjust for that. I was able to have him adjust the camera, but also make him aware that I needed to be aware of what was going on with his body at the time.
Mm-hmm. Yeah.
But mhm.
No, I find the same thing, but on the flip side, for me, from the pro side, I really like the fact that if a client, especially if a client is dealing with some sort of obsessions that are related to their home or someplace that they physically, habitate, all the time, that we can do therapy with them actually right there in their own kitchen or in their own bathroom or wherever it is that they have those issues. And it's something that I could never recreate in the office.
That is true. With the little boy that I mentioned, one of his fears was that his brother, who slept on the top bunk, would throw up into his bottom bunk. So he was able to lay in the bunk, for one of our exposures. So that's true, right?
Wow. Yeah. Yeah. So these are just some of the common questions and concerns that other therapists raise with me is well, I'm not comfortable if they're not in my office, or I'm not comfortable raising their anxiety, or, any of the things that we've talked about before. And the reality is, at least in my personal experience, that those are all positive things to be able to do the types of things we can do with telehealth that we couldn't do if they were in our office. Not to mention the number of people who don't have access to a therapist who's trained in OCD if they live in a more remote area. It's really hard. And that's another thing. And I think you've attended some of the support groups that we do. And we've got people who come in from all over the world because they just don't have access.
Absolutely. And also parents and spouses are able to attend your support group to educate themselves, which is equally important, really.
Mm-hmm.
Because if you have a family member who is not supporting you in the right way, it's extremely counterproductive.
So you actually hit right upon the next question that I was going to have for you, which is, not only are therapists concerned about, raising anxiety on the client's part, but family members, whether it be a parent, spouse, sisters, caretakers, anyone who's living with this person, roommates, they, especially if they don't understand what's going on and they don't know much about OCD and how it works, they're very concerned about doing anything to cause additional anxiety or distress for the patient. And so one of the first things that, I think all of us as exposure therapists do is we have to make sure that the patient knows that these loved ones cannot continue to accommodate them if they have been, and they most likely always have been, which is hard for that family member, because now you're telling that family member that they have to do something or refrain from doing something that goes against calming the patient. Well, if you calm the patient by helping them do compulsions, then you're just erasing all the work that the patient has done in therapy.
Exactly.
So, yeah, it's an interesting field. Let me ask, in terms of all the work that you've done with all the different types of patients, where do you rate OCD in terms of the how interesting it is to work with and how successful you can be once you start treating?
It is very fascinating. And like you said, because of one of the various forms that it takes. And I find now I have confidence now that I've been trained in ERP. Prior to that, I found it very difficult to deal with using what I was using.
Yeah.
Now I have confidence. I actually, when I have someone present with it, I feel ready to move in on it, and to my relief, and especially to their relief, it's highly treatable.
Yeah, and that's the thing that I think really drew me to a primarily OCD anxiety type of practice, is because you can have a patient who comes in on day one and they're extremely distressed and they've had a really tough time, maybe for their whole life or for years or whatever it may be. And they just don't see any end to their distress. And then you start working with them And like we said earlier, in a relatively short period of time, they can move from ultra high distress to much more, managed, reasonable, focused, and they're able to kind of catch their breath and, get back into life again. So that's the thing that really drew me to this type of a practice, because I like to see results. I'm a results-driven person.
Yep.
So, so any other comments or thoughts about working with OCD that maybe I haven't asked you about?
Well, I also take a holistic approach. You talked about yoga, mindfulness, nutrition, exercise. All of those things are extremely important.
Yeah. Actually, there's some, I've been doing a lot of research lately in the journals about different studies related to OCD treatment. And the thing that's really interesting to me is, if you look back over the last, I don't know, maybe 10 years, let's say, I've come across a lot of journal articles where the researchers will look at different medications or different supplements or things like that. And in many cases, they find some sort of beneficial effect, but it's just the beginning, and they state how we need more research on it, we need to follow through, but then you don't find any follow-up research. So there's all these things out there that show some initial promise, but they're not followed up yet for various reasons, I guess. So, there's a lot to come in the OCD field. There's a lot that's being worked on. We still don't fully understand where it comes from, but at least we know some treatments that help.
Absolutely.
So if somebody wanted to get in contact with you, do you have a website? How would they find you?
I don't have a website, but I have an email address. So it's my first and last name, Terri Pilkerton, TerriPilkerton @gmail.com. And I can give my number. It's 202-262-8624.
Okay. And again, your primary patient focus would be trauma, OCD, anxiety. Tell me.
Anxiety, ADHD. Yeah, that's pretty much right now the focus. Internal family systems is one approach that I use, along with cognitive behavioral therapy and some expressive arts mixed in there. I don't do I don't do expressive arts all the time. We do an approach, and whatever works at the time. I like to dip into that because the creative therapies access the right brain, which I think is important for delving into the more unconscious issues and feelings that are there.
Great. Well, thank you for taking the time to join us. And for those of you that are watching the video, we do have a free support group at stopmyocd.com. It's an online support group. Like I said, I know Terri has been there sometimes. You may even see her in the support group. So, no cost. Feel free to sign up and join us and learn more about OCD. Terri, I want to thank you for taking the time out of your busy schedule to help educate patients and other therapists about this field that we just seem to miss in school.
Absolutely. It was a pleasure, Andrew.
Well, thank you so much.
Okay.